Neurosurgery in the age of artificial intelligence is not just about image guidance, neuromonitoring, and safe neurosurgery. It is the most important evolutionary step which is going to transition us into a realm of really efficient procedures, and definitely it will help to improve outcomes in our specialty. This talk was given on Doctor's Day when I was awarded the Doctor's Day Award by the IMA Chennai South. And for us neurosurgeons, our training begins, as you can see that I am here assisting my teacher, Professor Ramamurthy, operating many years back. And then as a young neurosurgeon, earlier this is me operating at Mallar Hospital, and then later obviously at Apollo, where I currently am the neurosurgeon. The point is that, is it any difference? This is the normal evolution that is absolutely necessary for us to deal with the complexity, especially the complexity of the apex specialty, the emperor of all specialties, because of the severe pressure and not only complexity, this is the amount of knowledge which is required to be assimilated, and for the number of years we neurosurgeons have to train. And machine learning, big data, many model theory, augmented reality, brain-machine interfaces are becoming a part of neurosurgical training, and it is appropriate technology, as what my teacher Professor Ramamurthy wrote a remarkable paper in surgical neurology, that along with skill, compassion, focus, artificial intelligence would be the very important step towards safe neurosurgery. So it is going to change the way we do our pre-surgical planning. It is definitely going to make a major thing in intraoperative guidance, which is already there in form of neuronavigation. It, according to me, I personally feel that again, all neurosurgery was awake at a particular point of time, and then we do awake neurosurgery, especially when we want to monitor function. But I personally feel that utilizing AI, continuous monitoring, we perhaps may be able to monitor functions better when the patient is under anesthesia, and the surgeon is comfortable, the patient is comfortable, and we can definitely utilize, this is the latest textbook of Indian neurosurgery, the classic Ramamurthy and Tandon, and it will help us with this new knowledge to avoid complications, avoidance, and definitely we will be able to predict neurosurgical outcomes much better. So how we will treat future patients with peripheral nerve, spinal and cranial lesions is definitely likely to change. So we keep on creating data. We try to store our personal experience with complications, but probably the data storage and retrieval needs to be much more, especially in India. The huge data on oncology, deformity, degenerative diseases, trauma, infection and pain has to take off. It is I tried to get IIT Madras interested in collating with me to get this some ways of making sure that we are able to have this data and utilize this big data using artificial intelligence. The textbook actually has a complete chapter written on artificial intelligence and its applications in neurosurgery. And it is already there. Atlas GPT is revolutionizing neurosurgical care and education through the first AI-driven LLM collection for the neurosurgical community. And this definitely is going to transform our field. And not only it will transform our field, that we also need to transform, and we also need to sort of accept artificial intelligence as the next stage of evolution of the collective consciousness or the collective intelligence of our race. As Apuzzo brilliantly put it, the genesis of neurosurgery and evolution of the neurosurgical operative environment, prehistory to 2023, there was a lot of work which was done in India, especially on elaborating the things. So probably the prehistory part, we Indians were definitely the leaders for a long period of time, and then we transmitted that knowledge. And now progressive manipulation of minimalization of manipulation and emergence of more refined operative definition with increasing precision are evident with concurrent miniaturization of attendant computerized support systems, sensors, robotic interfaces, and imaging devices. So for us neurosurgeons, whether we are preparing the patient for surgery in our outpatient department or we are operating, to remain current, each of us should periodically reconsider his or her personal operative environment and its functional design with reference to the modernity of practice as currently defined. So AI for outpatient and surgical data collection, interpretation, discharge summaries are all the things. Already the most of our thing has been digitalized, and the paperwork which you see here is actually most of the time on the computer. You can take a printout for some people if they need, but yeah, it is become digitalized, and that helps in improving things. So now I'll start with showing you. Now this is a tumor which I operated, and if you can notice, it is in quite a difficult location, and it is a vagal schwannoma. And so we are using this, and as you can see that we have been able to utilize navigation to locate the lesion, and with precise neuromonitoring, as you can see, there has been very good functional excision, or what I call hybrid excision of this schwannoma. And as it's benign, we need not do anything. But yes, this results, the proximity to the great vessels in the neck is very close, and modern neurosurgery is exemplified by this careful removal. You have this another patient of mine with a median nerve schwannoma. As you can see that we are carefully stimulating the tumor, and
here, nothing here, nothing here. Which area from here? There is a fiber, I think. You get that? It is there. So we will not go there. There is nothing here, Papa. Nothing here, nothing here. Yeah, there is a recording button on.
So now As you can see that it's a large shaped one. We have been able to isolate it, but definitely we are not able to see the nerve. So first we will decompress the tumor, and then like how we operate on the brain.
Yes, sir. Yeah. So this is an option. It is going here. Knife.
So constantly verify the location of the nerve. Then we resect like an acoustic, saving the facial nerve. Here also the same techniques are used to make sure that our incision is parallel to the nerve root, and then we go ahead removing this peripheral nerve schwannoma in the usual technique by using CUSA, and thereafter making sure that we leave the nerve intact. And obviously in these patients, if earlier we had to transplant the nerve and use a nerve graft, the results were not very good, but definitely these things are improving and making our patients outcomes much better. So surgeons should first become expert in open approaches to the spine. And once they have mastered this fundamental armamentarium and know the anatomy well, they can apply to the minimally invasive surgery. So now if you read these biographies of brilliant surgeons, especially Sontag, who has been my hero, this gentleman now through small openings can occur large complications. So as you can see, this is a patient of mine which we presented many years back, and if you notice that a huge aneurysmal bone cyst is totally taken off this young woman's vertebral body, and this is totally destroyed. And I not only stabilized her, and then I recreated the complete vertebra using bone cement, and she recovered once again, and that time again we had to go retroperitoneal, and now she is doing quite well, and with nearly more than 10 years of follow-up. This is another young lady, and as you can see, on her first post-operative day, she's a computer thing. So on the first post-op day, she is able very comfortably to use her hands and do the thing. And as you can see, we have done laminoplasty, and we have placed her thing, and there is a total excision of the intramedullary tumor. And the functional outcome on first post-operative day, where she is able to be back to her and she's ambulant, is all possible. Is all possible because of current monitoring. So, complex tumors like this, it would be impossible. In fact, this screws I had to put using navigation, because the entire anatomy, as you can see, has been quite damaged. And this is him after surgery. As you can see that his quadriparesis is better. And this is him on the 14th post-op day. He is able to walk, and this is with him on 3 months later, where he has improved. So it is possible with navigation and with and once artificial intelligence paradigms are applied to this, we will definitely be able to do much more precise surgery. This is a hangman's fracture, another hangman's fracture which I operated many years back with C-arm and microscope and the high cervical approach. And this is a series of patients. The initial series of my odontoid screws were placed with X-rays, and then obviously C-arm and neuromonitoring, and navigation definitely makes our life very, very easy indeed. So in the elderly, you can see that the era of things. So these are elderly patients operated by me at OMR Apollo, and you have the age range from 85 plus to 92. And as you can see that these elderly patients are able to be mobilized and they are able to respond to such a type of thing. Again, neuromonitoring and modern microscopes and imaging definitely is useful. Now coming to a very common operation, it is a very common thing. The burden of lumbar disc is huge, and it is the operation for which we are sued. Also, neurosurgeons are sued all over the world for a lumbar disc, because the spectrum of complications can be really huge, and it can be devastating to the patient. But obviously, when the pain is so severe and there are neurological deficits, now minimally invasive tubular approaches, and I routinely have been using neuromonitoring, and this has been done by Nancy Epstein. She spoke on this, and she also was of the opinion that when we take this we monitor the nerve roots, and in these patients the nerve roots are so close and proximate to the deep that it's very, very difficult even under magnification and endoscopic high view to clearly identify the nerve roots. And so we, like in vestibular schwannomas, we require to stimulate and make sure that we are able to do this. This is another thing which I have sort of pushed for in India, and this is we are doing work along with the IIT, again trying to see how we can use navigation to make sure that these misplaced catheters, in a shunt, are placed very precisely. And as you can see, the placement of these intraventricular catheters has to be done, because we really cannot have another surgery, and the precise placement is made much easier by navigation. So as we progress, we will keep on having more and more of these tools, where we'll have for example, neuro-IGN. I have not got personal experience, but this is multimodal image guided system for precise brain tumor surgery, and this is already in clinical practice. And so we have to, pattern recognition. So now when the patterns have to be recognized, you really cannot interpret this big data without artificial intelligence. So this has to go on to neuro using. So now this is by Dufo, that you need to as neurosurgeons constantly keep getting yourself up with the various technologies to make sure that every patient's individual anatomy, entry points and operative corridors, and also the exact extent of tumor infiltration is recognized by these various tools. So when you have many big data, then we use many models, and then obviously generative AI for brain imaging computer network, this is likely to become the norm. This is a patient I have operated here at OMR Apollo, and this gentleman had recurrent glioma in the motor area. And you can see that we have used the tractography to define that his tumor is located on the left side, and it is so now we have still not become careful or conversant with the connectomes, but yes, already it's a part of the repertoire of many neurosurgeons, where connectomes we really realize what the tumor is happening, then do these surgeries under neuromonitoring, which will keep getting better with time, and then or we do them awake to make sure that we give a first post-operative smiling patient like this. So deep-seated tumors, which used to be earlier very, very difficult, as you can see, these tumors are deep and vascular, and as you can see, this my post-op shows that we have not only excised the tumor, but we have made sure that there is no collateral damage. So same thing, another patient of mine, you can see that I have done the resection of this tumor with the supramarginal resection, and this is the current standard of care. This is another patient of mine operated at OMR Apollo. As you can see, I have used the tractography to see how the tracts are displaced posteriorly. Again, it is a very, very difficult, dangerous tumor right on the motor, and this gentleman, after the second surgery, was in the US living alone, and he is a software consultant, and he was practicing. As you can see, this is another astrocytoma. This is my first post-op. This lady had conceived had delivered a child a few days back, and this is the first post-op day after a surgery. You can see the bicoronal incision. So we make incisions which are cosmetic, And again, using neuromonitoring, she has got a functional. This is her many years later, and that small baby has grown up, and as you can see, these are the outcomes which we aspire to. So now in pituitary tumors, again, the earlier we used to use the lateral radiographs, but again here also, perhaps more than anywhere else, this is one of my recent patients at OMR Apollo, where a pituitary tumor has been resected. And it is very, very important that we need to have this type of so another patient, and as you can see, that we are not using retractors in surgery nowadays, and we use the proper trajectory and make sure that the incomplete tumor is removed. And this is the patient on the first post-operative day. This is another patient with this is a schoolgirl who came to me with this hypervascular tumor of the frontal disc, and as you can see that I'll just rush you through the surgery, that this is the pre-operative tumor, and this is her peroperative surgery. And as you can see that we are removing the tumor, and while we remove the tumor, we try to make sure that we are not retracting the brain at any point of time, and we keep on removing the tumor till we have excised the tumor completely. And this as you can see, whether we are using the CUSA or the various things, this and the entire thing I will not bore you, but yes, the patient again I call this the bank robbers technique, where you go in quietly, you remove the brain tumor completely, make sure of proper cosmesis, make sure the bone reconstruction is proper, and close the dura meticulously, and put a proper flap so that the outcomes are excellent. And as you can see, this is her post-op, and these are other few of my patients. So this retractor leg surgery is a very, very important and it's so now what I'm saying is that every new adjunct or device which can be used should be used to continue to refine and evolve our neurosurgical specialty and better ourselves each day. And as you can see, this is the keyhole surgery, a minimally invasive surgery, which is done through the eye. This is done, and these are a young woman with meningiomas of the anterior cranial fossa, and this is a minimally invasive. And you can see the optic nerves here, and you can see that we have enough vision, and this tight tumor which is causing pressure, we remove it completely, and the outcomes, post-operative outcomes are really good. Another lady who did not walk for nearly 2.5 years, and this is a huge petroclival meningioma, and as you can see, this is the post-operative thing where there has been a very good resection of the tumor done, and this is her walking after some time. So we need to show this. We need to see that our microsurgical skills and collective neurosurgical consciousness is constantly evolving, and our outcomes are exposing. So the microsurgical skills require years of mastering, and this retractorless safe surgery is very important, where on the first post-operative day at OMR Apollo, these are what we like to see, that how and neuromonitoring is literally become the essential adjunct, especially for these important lesions, whether it's an AVM or anything in the motor area. This is another thing. So this is another giant MCA aneurysm in a thing. So, and as you can see that this is aneurysm being clipped at again OMR Apollo, and this is a lady many years later. So the outcomes are very important, and navigation and all these things are very useful for even aneurysms. And in vestibular schwannoma surgery, this is another acoustic, and most of my acoustics which we do are currently what we practice is the functional surgery, functional hybrid neurosurgery with neuromonitoring. The very important thing is to make sure that the smile is retained on the faces. We cannot, whatever the small residual tumor can be followed up, and depending on the follow-up scans, we can decide whether we can give them radiosurgery for the residual or keep watching them. So whether it is this, in neurotrauma, the neurotrauma is a big thing. This is a small child with a extra posterior fossa extradural. The child is happy in the post-op period, but the point is that when to intervene, how to intervene, what is the timeline, all this, and whether the neurosurgeon can be alerted as fast as the patient comes, because quality in neurosurgery is the time from the emergency to the OR, especially in posterior fossa extradurals or any extradural for that matter in young people. That is, the emergency to the OT time should be very, very small indeed. These are various patients with trauma, and significant work was done in 3D printing these flaps, so that the eventual cosmesis after surgery, after such disastrous trauma, we are able to give very good results. This is another problem. This is a patient, recent patient operated by me at OMR. It's a colloid cyst, and these are notoriously difficult, and we need to perfect not only the technique, but we need to keep on evolving the perfect trajectory to these deep lesions, so that we can have both the patient and her mother were giving my thanks, and the patient on the first op day should be, I think she's doing well. She's completed her course after surgery. So I am not celebrating spectacular surgery that we all do when we do a few cases, and then we are very proud of that. But every case, whether it is a relatively simple case like lumbar microdiscectomy or the safe surgery is the highest level of neurosurgery. My nurses, both inside the theatre and in the wards at OMR, are exemplary. In fact, they are my biggest strength, because depending on these people, I am able to satisfy both the institution and my patients. And this is very, very important that we not only at Apollo maintain the standards which have been set by our chairman, and this is Dr. Pratap Reddy, appreciating the huge work which we did with the textbook of neurosurgery, and he wrote a remarkable handwritten note on my copy. So thank you, doctors, for your attention, and obviously the people who have interested and waited to listen to my talk. Thank you so much.